and welcome to our presentation on biosimilars today, talking about biosimilars in practice and how we can help maintain access and make sure along the way we're, of course, prioritizing patient care. So we'll start with some introductions. I will introduce myself first. My name is Kathleen Stenberg. I'm a lead specialty pharmacist of operational excellence here at AcariaHealth. So I do a lot of regulatory compliance pieces, making sure our processes and things like that are compliant while also patient-centered. And I've had experience with therapeutic interchange in the past, which has exposed me to the wonderful world of biosimilars and all of its complexities. So I will turn it over to Alysha to introduce herself.
Hi, everyone. My name is Alysha Robinson. I'm AcariaHealth's Director of Specialty Pharmacy Program Management. I'm also a pharmacist by background. In my role, I have oversight of the team that supports maintaining patient access to these life-altering therapies. And I also have a background of working closely with payers. And Robin?
Yes, thanks. Hi, everyone. My name is Robin Waida. I am the Physician Sales Regional Director for Central for the U.S. I've been with the organization about 19 years, so I've seen lots of changes throughout the industry during this time, and have actually been on your side of the desk. Prior to joining the ranks of AcariaHealth, I was actually an endocrinology nurse practicing and dealing with growth hormone and all of those lovely medications. So I've actually been on your side of the desk and understand some of those challenges that you're facing in the industry today. So thanks everybody for joining the call. I'm excited to get to know all of you. So, what better way to get started understanding, biosimilars than to have a potential case study? And so that's part of the clinical piece of me and something that I think you all will kind of relate to. So let's take a moment and let's meet Kathy. Kathy is a 72-year-old female. She's been diagnosed with Crohn's disease affecting the small bowel. And our treatment plan for her is Stelara injections. And Kathy's actually getting administered this medication every 4 weeks as part of the dose escalation protocol. And that's really due to the severity of her condition. And so she's been receiving medication from the Stelara specifically from AcariaHealth since 2016. And so in June of 2025, when processing a refill for the Stelara therapy, we received a rejection of a test claim due to the product service not covered. And that's kind of pharmacy language. But basically what that meant was something had changed with her plan. And so upon further investigation, it was determined that the plan had changed their preferred formulary. And now Yesintic is going to be the preferred medication for this patient's insurance moving forward. And so, Kathy's pretty apprehensive. Again, let's think about her, her age here. She's 72 years old, right? And so she was very apprehensive about switching to a new therapy. And she did call the provider office. And I think that that's an important part of this because, what had been shared with Kathy was that, Stelara was no longer covered and that Yesintic was going to be the preferred formulary. But what Kathy heard was she was no longer going to be able to get her medication. And so she was very concerned and she notified the office of that. So I think we'll pass it on over to Kathleen now that we've gotten a small introduction of Kathy. We're going to be checking back in with her throughout the entire webinar, but let's turn it back over to Kathleen so that she can talk a little bit about biosimilar and some of those misconceptions.
Absolutely. So thank you for introducing us to Kathy. We will be trying to make this a little interactive, kind of break some things down because biosimilars can be quite complex. So we've put together some facts and some misconceptions on various subjects related to biosimilars, and each of us will take a piece, and you'll get to participate and identify which one of the three statements is a misconception, and we'll offer some information, background related to those questions. So you'll be using the poll function in Teams to participate with us. We'll kind of start with covering the basics of biosimilars just to make sure everyone's up to speed on the basics of pharmacy and regulatory compliance pieces. You may already be familiar with some of that, but just want to set the stage with that. And then moving on to formulary considerations. And then, of course, steps to make sure we're ensuring continuity of care during those biosimilar transitions. So we are going to be launching our poll with these three statements, and your job is to spot the misconception. So our three statements are: biosimilars are the same as generics. All biosimilars are proven to be as safe and effective as the reference biologic, which is another way to say the brand name product, regardless of their interchangeable designation. Or is it biosimilars, which are not interchangeable, require a new prescription to switch from the reference product? So I'll give you a moment if we can get the poll launched. Looks like it's up. So feel free to submit your response. We'll give it a minute. Right, seeing some results coming in. Don't be shy. I see we're only like halfway responded. You're doing good. Okay. So of those who responded, it looks like you were very good in spotting the misconception. In second place was the one I was hoping would be the truth that would be a little tricky. So on the next slide here, let me get my screens back together. I will say what we're talking about. Okay. Ta-da! If you chose the first answer, biosimilars are the same as generics as the misconception, you would be correct. The second most common response was the second one, that all biosimilars are proven to be safe and effective as the brand name product, regardless of their interchangeable designation. And I'll talk about that on the next slide because that was a tricky one for me to understand. But pretty much everyone knew that the last one was true. So. All right. So kind of delving into that a little bit more, you're correct that biosimilars are not the same as generics. There are certainly some similarities. There are certainly some differences. So just to do a high-level overview of those, again, just to make sure we're on the same page, both the biosimilars and the generics are proven to be just as safe and effective as their brand name counterparts, with no clinically meaningful difference. So you can be confident that they are going to have the same outcomes for the patient, regardless of if they get the brand name or reference product or their biosimilar generic versions. What the differences come down to then is at a molecular level. So how the drug itself is made, or how large it is. So generics are much smaller molecules, and they're much, much easier to make copies of. So you can have an exact copy of a brand name and a generic. For biosimilars, it's a little more tricky. These are products that are made from living sources, and just inherently as part of that, they can't have exact copies, but they can have near copies because they're very large molecules. My favorite analogy, and I'm sure everyone here is probably tired of me saying it, but the FDA has an analogy out there that I really like, where they compare biosimilars to loaves of bread. If you use the same ingredients and follow the same recipe to make two different loaves of bread, they will not be exact copies of each other just because flour, yeast, those types of things are made from living sources. So there may be slight variations, but at the end of the day, you have still two loaves of the same bread. So that's just an easy way to kind of visualize it for patients and providers, whoever you may be speaking with, that they'll be getting the same benefits. There's just very slight, not insignificant changes. um, and then as far as biosimilars, there can be device differences between the brand name and the biosimilar. So on the screen here, in Kathy's example, her original product was Stelara on the right, and Yasintec is the biosimilar on the left. You can see the way the syringe is kind of configured is just slightly different. So the Yasintec has larger flanges, may be easier for her to hold on to. If this was a adalimumab or Humira example and it was pens, you could see even more differences between injection devices from the brand name to the biosimilar. So point being that education is key for these types of switches, especially if a patient is accustomed to one and switching to another, and not just starting fresh on a biosimilar with no other experience for that drug. So really being open and clear about those differences so they're not caught off guard and feel confident about taking their medication. As far as interchangeable biosimilars, it is a special designation to have interchangeability status. And essentially, it is a paperwork situation. So manufacturers have to submit additional information to the FDA to specifically get that designation on top of being a biosimilar. At least as of today, there's some legislation in the works that may change how all of this works. But for now, additional information is required. However, and this was my tricky truth, just because an interchangeable product or just because a biosimilar is interchangeable, it does not mean that it's more biosimilar than another drug that doesn't have that interchangeable designation. And so why would a manufacturer do this if it really doesn't say anything different about safety and efficacy? And it comes down to substitution. So biosimilars that do have that interchangeable designation are able to be substituted at the pharmacy level without getting a new prescription from the provider. However, and this is a big however, there are additional steps that need to be taken to ensure compliance, and every state is different in what they require to allow pharmacy level substitution of interchangeable biosimilars. So that includes things like patient consent, patient notification, prescriber notification. So regardless, we're going to have to reach out and let you know, A, we either need a new prescription, or B, we made a switch and we have to notify you legally. So that can get kind of hairy. There's some systematic constraints just in the way biosimilars kind of map to each other and things like that. It's not the same as generics. So usually the quickest way to make sure we're compliant is to have a new prescription sent in. It eliminates the determination of, is this interchangeable, is it not? Because those designations do change over time as more and more products become interchangeable. So I recommend sending in a new prescription if a patient is deemed to be eligible for that biosimilar. You're not sure if we can substitute at the pharmacy level or not. It'll just expedite the patient getting the therapy that they need.
So, when we think about formulary access as it relates to biosimilars, we're going to look at which of these is a misconception. So again, please use the poll feature to weigh in and we'll go through them. So the first statement is, as new biosimilars have become available, the complexity of plan benefit design and formularies has increased. The second, rapid shifts in biosimilar use have been observed following removal of reference products from formularies. And the third statement, plans only update their formularies on predetermined dates throughout the years. So let's see, I'm starting to see a couple of few responses come in, weighing in a couple directions. Please do weigh in. See if you're able to see which one is the misconception versus which one is more truthful. Which two are more truthful, excuse me. So picking out the misconceptions. Still a few coming in. White. Okay, looks like we have a bit of pause. It's a bit like watching popcorn. So let's go ahead and go to the next slide to see where we land. So most everyone picked the last option, which are plans only update their formularies on predetermined dates throughout the year. And yes, that is a misconception. And so if you chose that last option, is right, but I'd like to dig a little bit deeper. And I want to start by talking about the pace of change. So, particularly as it relates to biosimilars within the pharmacy space, it is happening rapidly. In fact, a well known large PBM removed Humira from its formulary in favor of the biosimilars. And in just 4 months, they were able to see a 97% shift into the use of biosimilars. This supports the view that formulary change drives biosimilar adoption. But what does it mean for you from a day to day perspective? As advocates for our patients, you are likely already seeing the impact in the form of prior authorization changes, claim rejections, and even appeals that can add to the challenges in helping patients to receive and maintain these therapies. Further complicating this rapidly shifting landscape, the timing of these changes can vary widely. For government sponsored plans, of course, the timing is often guided by policy and regulations. But in the commercial space where there are the most patients, the timing is considerably more variable. So, what is there to be done? While you may not be able to anticipate when the changes are going to occur, understanding the types of changes that are likely to occur can help you to support patients and their families along with the offices. So let's take a couple of moments to talk about what types of changes you might see. Before, generally, there was a one-to-one match of the biosimilar to a reference product. Now, with the biologic to a reference product. Now, with the same active ingredient, it can be available not only as that reference product, but also in any number of branded and unbranded biosimilars. Accordingly, formularies have added complexity in order to be able to integrate these biosimilar products for health plans, PBMs, and even plan sponsors. What that looks like is that it tends to take more commonly one of three shapes. The first looks like a co-preferred strategy, and this is where the reference product and the biosimilar are both on the formulary, and you can choose between either of the two. The second option you see where the biosimilar is added and it's preferred. So in those cases, often trial and failure of the biosimilar is required, or the patient has to be otherwise not eligible for the biosimilar in order for them to maintain access to the reference product. But both products are still on formulary. In the third option, you see the complete removal of the brand in favor of the reference product. So as I noted in the initial example, this is the most drastic, but it's been the least common so far. The simplified summary of all of this is that the changes in formulary strategies are happening in real time, and they're impacting patient access to therapy and the work that you're doing. I'm going to turn it back over to Robin to revisit Kathy and what collaboration with the specialty pharmacy looks like to help navigate this.
So, I'd be interested to see how many of you have been in this situation. It's got to be completely frustrating for not only the patient, but you as the caretaker, right? So let's visit back with Kathy and really talk about essentially caring for her during this transition. Some of the challenges obviously that we're going to face is the preferred drug, formulary changes, the education on the biosimilar efficacy, as well as potential lapses in therapy. So, for me, looking at this from a clinical perspective, it's assessment and obstacles, right? So the continuation of therapy, that's required for disease management and adequate patient care. And ultimately, this is where we see a lot of patients that have the risk of potentially lapsing in therapy. And that's ultimately the worst case scenario. So Kathy's personal objections led her to not only canceling her Yacentic delivery, and actually shipping it back to AcariaHealth, because as she received it, the medication, it looked different, right? And so that was a great point that Kathleen brought up is the medication itself and the delivery mechanism looks different. That scared her as well. But there wasn't enough education, I feel like, in this case study, really, collaboratively in the very beginning. And so we're going to kind of see that, grow throughout this presentation. But ultimately, in this particular case study, she scheduled the delivery, she received the medication, it looked different, and she actually shipped it back. And so obviously when that occurs, ultimately there's a lapse in therapy, but also there's a wastage of product, right? And so lots of challenges there. This ultimately ended up in about a 2-month lapse in therapy. And so, the obstacles included the health plan's preferred drug formulary change, right? But also the lack of the biosimilar education piece. And that can kind of added to the lapse in therapy. Kathy's personal objections led her to not only canceling the authentic delivery, but as we said, shipping it back to AcariaHealth. And ultimately, this ended up where she was, had achieved a very comfortable remission place in her treatment, but then that went away. And so much so that she was very hesitant to even communicate with the pharmacy afterwards. So we're going to go into another misconception. So everybody get ready for their polls. And this one, I think we're going to get a 100% here. I'm having this feeling. So the 3 misconceptions that I have, most patients are unfamiliar with the medical terms like formulary changes or biosimilars, which can lead to confusion about the prescription and treatment options. The next option would be specialty pharmacies are always notified in advance when plans change their preferred drug list for established patients. And then third option would be aligning with the specialty pharmacy prior to biosimilar launch for patients they dispense to can significantly enhance continuity of care and streamline education efforts. So I'll give you all a moment to review those 3 misconceptions and see which one you feel like is accurate. And let's see. Very good, very good. We're up to about 85%. So those of you that selected specialty pharmacies are always notified in advance of plan changes to their formulary. That is correct. We are not notified. So not all the time. And, I think that it's important that we touch back a little bit more on, the other options, right? Let's talk through a little bit of those. Multiple surveys available show that approximately 70 to 90% of patients, including the general population and less, exposed patient groups, right, lack familiarity with terms such as biosimilar. And this often results in a lot of confusion about the treatment and access options. And, we'll talk a little bit more later in the presentation about some different marketing materials that we put together, really helping patients with this education piece that are going to be available for all of you, but really having them understand why is a biosimilar so scary? Why is that term so scary? When generic is something that we say and we all take for the most part, and we don't get scared about that. So why is it that a biosimilar, that term, really scares patients? So really keep that in mind as you're talking with your patients and as they're transitioning, especially going into this time of the year, that 70 to 90% of patients do not understand terminology of biosimilar or preferred formulary. That was really alarming to me. So talking a little bit more about the why, right? So specialty pharmacies are always notified. We're really not. And in many cases, we're not notified until either you at the office call us that a patient brought in a letter they received from the insurance plan, or if the patient contacts us directly, Or in some instances, it's not until, like in Kathy's instance, that we go get ready to refill her medication and we receive a rejection that basically, gives us a warning that something's changed. And then, again, proactive patient education. That's really where I feel like specialty pharmacies can step up and help bridge that gap. You, as our biologic coordinators and our clinical nurses and our medical assistants, you do not have the time during the day to spend as much time with each patient, especially a patient as Kate and Kathy's situation that's 72, that, our older geriatric patients sometimes have more struggles with that comprehension, right? To really walk them through this process. So the more that we can collaborate and educate these patients on what a biosimilar is and why the insurance plans are pushing, in that direction, I think the better that we will have as far as, lack of patients, less patients having lapses in therapy. So, we want to always make sure that we're delivering this consistent messaging and align with the prescribers to avoid any type of confusion. So, recommendations that I would have, obviously, in Kathy's situation, in ways that we could have avoided some of the lapse in therapy, is enhanced provider-pharmacy collaboration, more clear communication channels allowing the prescriber to share, the clinical preferences with the specialty pharmacy to relay patient, that feedback to the patient. Also, tailoring support to high-touch patients, right? So what is your specialty pharmacy doing for you as a provider and as an extension of your provider office to personalize that education, support calls, resources, so that it can be an actual resource for you. And then, also specialty pharmacies, we can streamline the coverage, right? And access navigation, we can help streamline that for you. We can proactively manage the PAs, the prior authorization requirements, and trying to minimize last minute barriers and workflow interruptions. I think the key takeaway from this section, as we checked back in with Kathy, is really knowing that early alignment with specialty pharmacies really does ensure a smooth biosimilar transition, enhancing patients' confidence and avoiding unnecessary treatment delays. So I will go over to the next misconception here. Let's see if y'all can spot it. All right. So first option is going to be clinical teams are rigorously trained in insurance processes and biosimilar interchange protocols. The next option would be prescribers and clinical teams base therapy off what is aligned with each individual patient's care plan. And our third option would be lapses in patient therapy not only affect the patient, but also put strain on clinical care teams. And let's see where we're at. Wow. Very, very good. Yes, it looks like it right now about 86. It's trending. The first option is the clinical teams are rigorously trained in insurance processes and biosimilar protocols. That I think that's a huge misconception, and something that we can absolutely improve on. Oftentimes clinical teams learn. With time and experience when navigating these challenges related to insurance coverages. There's no formal coursework or training that's involved. And quite honestly, going back to the amount of workload that's on our, doctor's offices and our biologic coordinators, even if there was this training, let's be honest, is there actually really time? And as much as the industry is changing and there's biosimilars continuing to come up, it's once you've learned all the Humira, how to say all the Humira biosimilars and pronounce their names, there's more that are coming, right? So the truth here, quite honestly, is prescribers and clinical teams, they base the therapy off of what is aligned with each individual patient's care plan. And, while collaboration with the patient health plans, it is necessary, and clinical teams, are experts in the field essentially, and each patient's care plan is unique to the diagnosis and medical history. Health plans do not, they don't get to know a patient and their needs for their best clinical options, or really getting to understand or know that the clinical team and what you're having to go through behind the desk. I think from experience in this, and again, I've been with the organization 19 years, the goal, of clinical care teams is truly to treat. At the end of the day, as specialty pharmacy, and sitting here right now in front of you all, I don't care which drug you write. I want to get linkage to care. I want to get that patient on therapy, keep them on therapy with no lapses. I want all of our patients to achieve remission. That's truly from the heart of what we do, is putting that patient first. When there are bottlenecks in the place that prevent effective treatment, patients, they're going to become frustrated. You're going to become frustrated from the clinical team. Teams experience performance pressure, and conflicting information is received by the health plans and the pharmacies alike. Thus it's just a truly negative cycle. So let's check back in with Kathy. Navigating a care plan for Kathy, it really takes a management plan and a collaborative effort between the pharmacy and the doctor's office. It's Kathy and her continuation of therapy is our top priority, as we've stressed, right? It's imperative that we, do all that we can to evade any more lapses in her therapy and honor her fear and concerns. I think that's a very important piece to this. Validating a patient's fear and concern is incredibly important. We all do this every day, and we get so sometimes complacent where, it's a matter of fact, your plans change their formulary. In order to stay on therapy, you're going to have to try this medication. That route can work with some patients, but in Kathy's situation, she needed a lot more hand-holding, and she needed to be heard and make sure that her fears were not necessarily validated, but were at least listened to and understood. So, it's incredibly important that, patient follow-up, counseling, that's required by the care team. And, that does involve her healthcare provider and the specialty pharmacy to educate on the biosimilars. Communication with the specialty pharmacy, when Kathy started having these reservations, that direct line of communication with the sales rep or our provider experience manager clinical team to the doctor's office saying, hey, Kathy's unsure if she wants to continue on this therapy. I think bringing her in for a doctor's appointment, or at very least maybe a telemed, so that she understands that you're comfortable with this change, would really be beneficial. So, education is key. Formulary changes lead to an increase of phone calls, written correspondence, new authorizations, and again, it causes confusion and panic for all involved. It sounds kind of like a sales pitch, but I will tell you, having been on your side of the desk and having done this as long as I have, aligning between the specialty pharmacy care team and the patient, it's necessary to achieve continuity of care. It's incredibly important, I believe, as being on that side of the desk, and also being a rep and now a director for the organization. It's important for provider offices to notify the specialty pharmacy when you receive any type of notice by the patient's health plan regarding changes to drug formularies. This just ensures effective cooperation and avoids lapses in therapy. So the moment that you receive anything in the fax or in the mail, notifying your dedicated pharmacy associate is key, so that we can get involved immediately. And again, we will be sharing with you a new piece that we've created. And this is one that I think will be very helpful for patients as you start to really have these conversations going into the new year. And it really takes them very simplistically, a biosimilar versus a generic, and what that looks like. And to try to help to remove that fear from these patients of that term, and help them to be, more notified, more educated when it comes to these changes. So I will go ahead and open it up to any questions or answers that you may have regarding our presentation. and we really welcome all of the feedback. I'm hoping that a lot of you in attendance today are some that we met recently at the Healthcare Advocate Summit. I had some wonderful conversations with many of you, and I would love to hear from you if you have any questions, any suggestions or feedback for the collective group.
Absolutely. And while we're waiting for any questions to come in, I do have the QR code up on the slides here to download that wonderful patient resource that Robin just talked about. So it will be here in that QR code. I think we'll also be sending it out afterwards with an email. So just wanted to point that out. Okay. And do we have anything in the Q&A,
early
question.
Yeah. Deals with how around the patient conversation. So, Robin, you mentioned the importance of having early patient conversations with them what they have to switch. But before a switch happens, is there anything conversations that preemptively could be taking place to help prepare in the event that they do get notification about the need to switch to a biosimilar?
Yeah, and I don't know if that's questions directly to me, but I would love to hear from somebody that's in attendance today that are actually in the trenches working with these patients. Biosimilars are not going away, and if anything, we're starting to see them go into other disease states. At the Healthcare Advocate Summit, we spoke with some representatives there, and they actually were talking about neurology. They were really scared, right? Because they've been hearing what has been going on in dermatology and rheumatology and gastroenterology, and they know that wave is coming towards them in the neurology space. So I think that you can never start having these conversations soon enough. I hope that everyone on the call understands that as a specialty pharmacy, again, we have no preference, right? We want to keep this patient. We just want the opportunity to service this patient and have linkage to care. But we also have to understand in our current landscape, how do we work with the plan? How do we work with the patient? How do we share best practices as far as documentation for patients who potentially have an adverse event, or a patient who we don't want to have switched? Those are all conversations that we're open to having. But I think that it's incredibly important for any of your patients that are on a biosimilar right now. It's a conversation to have at their follow-up appointments as we go into the new year, because we are going to see more and more plans pushing that direction. Let's be honest. I wish I could see everybody's faces right now, but we were working on updates to our Crohn's and UC referral form, and we have Remicade, right? You have infliximab, right? So that's one of my pharmacists are going to have to correct me if it's a biosimilar or bioequivalent, right? So from there, you now have Zinfentra, which is a biosimilar of infliximab. So it's not going away. If anything, we're only going to see this more. So how do we work collaboratively to make your lives easier, but ultimately getting patients to stay on therapy and have continuity of care?
Yeah, absolutely. I think I've always said any little nugget that you can grab onto about any potential changes that may be happening for one patient, start thinking about how that affects similar patients who maybe have the same plan and things like that. So definitely, every little piece counts, because it's sometimes few and far between, and you don't want to find out at the last minute. Anything that you can do proactively in between fills to get prescriptions updated, get prior authorizations updated, is always, a good thing. Sometimes we just don't know ahead of time, in which case, just working collaboratively and as closely as possible is key, along with education for everyone involved, truly. In the Q&A, we had a question and an answer from one of our participants, but just wanted to to say it out loud in case anyone wasn't following in the Q&A, but it's regarding copay cards and asking if patients can use the same copay card if their prescription is updated to a biosimilar from brand or to a different biosimilar? And the answer is no. If they're switching from Humira to Siltezo, they're completely different manufacturers, they're different programs entirely. So making sure that if a patient is relying on copay assistance or patient assistance funds, that you're making sure they're signed up for the correct program to continue to receive those copay benefits and coverage. So certainly pharmacies are well positioned to identify programs that are out there and help connect patients to those, make sure that they're getting enrolled if they need to get enrolled, so that the cost remains affordable and doesn't become a barrier as well. But I didn't know if anybody else had anything on that as well.
Yeah, and I would entirely agree with that. That because that one-to-one, it used to be a lot simpler. There was only one place for that biologic, it was only one source for it, and that has changed. And so it does impact, and it's really, I think, a great question to be thinking about, not once the patient and you determine what's the best medication for the patient, but what that access picture looks like and what the patient responsibility could look like as a result of the change. So, I think it matches the themes of what's been shared, which is that it does change quite rapidly, and that this is in some ways a newer frontier for navigating the self-administered medication front.
And I had a thought. Kathleen and I had a situation with a patient, and Adasio, right? For those of you who may not know yet, that is actually being phased out. And so it's got to be frustrating. And I would love any kind of feedback that you can share with us. As you get these approval letters or even potentially denial letters, a lot of times the plan will provide 2 or 3 different medications on there that the patient is approved for, right? So if they deny the Humira, they'll provide some other medications, right? One of the biosimilars, and then you send the prescription for that, and then the pharmacy comes back and says, we don't have access or we can't get it, right? And then you got to send another script, and I don't know how many of you are going through that. I know I've had some offices that have expressed frustration with that, but we just learned, I think it was last week, Kathleen, with Adasio, that is actually being phased out. So now that we have all these biosimilars and all these what we call NDC numbers, right, for each dosage, and drug itself, the FDA is trying to get away from so many NDCs, and so they're starting to kind of phase out some of the branded biosimilars and going to more of a generic analimumab, wanting you to send it over as a generic analimumab. I mean, Kathleen, Alysha, what are y'all's thoughts on that? If an office is frustrated because they're getting to the denial letter and they send that script in, but then the pharmacy comes back and says, we can't fill that, we need another script. Is it better just to send it over as unbranded analimumab? Would that help cut down on some of the back and forth?
So in Adasio's case, it's just the branded version that is being phased out. So the unbranded, I don't know what their 4-letter extension is. So what's different but with biosimilars versus generics is that 4-letter extension will tell you which specific version of that drug, which manufacturer of that drug is being prescribed. So if they were to send over a prescription for adalimumab, 4 letters, that would be fine. It would match to whichever manufacturer is preferred. So if they were to just send over adalimumab with no 4 letters after that, that's technically Humira. So the tricky part comes down to that the extra 4 letters at the end does has a lot of impact. 4 little letters that don't make any sense in the world can make it tricky in what we can switch to and what we can't switch to.
And I'll add to that, is that as EMRs and e-prescribing platforms catch up, that's also adding a level of complexity that wasn't previously much of a concern in the biologic space. So as long as you knew the brand name of the product or you typed in adalimumab and you got the one adalimumab product, you knew what you were prescribing. But as that has added complexity, there's been a little bit more back and forth. And I'll be honest in that pharmacies are having to navigate those same changes within our systems. And so, we're always looking, I know at Acaria, for ways to streamline that experience and share proactively how to share that information. But I think it's a great plug for working with the specialty pharmacy to understand it. Another complexity that we haven't really discussed is access to all of the biosimilars. Generally, with generics, because of their wide availability, their low price point, every pharmacy had access. But similar to some of the limited distribution arrangements that you see in other specialty medications, we are also still seeing those in the biosimilar space. And so, working with the pharmacy can help you to navigate that, determine based on which options are available on the formulary, which what would be available from the pharmacy to maintain that continuity, while at the office they can choose a product that's best aligned to the clinical picture for the patient.
So I just put in our Q&A, you guys. these are those four-letter abbreviation, and from a clinical perspective, what is that known as? We know it's unbranded, but what does that signify? Those four, and
It's the
how many in the?
manufacturer. Yeah.
Okay. So, I how often do you get a pharmacy who says it needs to be switched to an analimumab ATTO, and you're supposed to know, oh, that's Amjevita. So I think again that's
Yeah.
we're sharing in that reality and those struggles with you guys. So yeah, I had an office very confused the other day, but then that was when we identified that the brand one of the brands they're actually being phased out. So I think we'll see more and more of that unfortunately occurring.
Yeah, I think it's just so foreign because brands and generics, you can prescribe the brand name. You don't have to specify the manufacturer of the generic you want. In this case, you do need to specify the manufacturer of the biosimilar that you want. So it's a
Mhm.
whole different world, and 1000% agree. It's very confusing and hard for everyone involved. So, which is why we're trying to have these biosimilar presentations and things. So, the struggle is real. We understand. Call and ask us if you're confused, and we'll try to help you.
On
Something
our
interesting
website,
about
you'll
that
see.
suffix.
Go
Something
ahead, Alysha.
interesting about that suffix is that when they first started biosimilars and first created the regulatory pathway for it, they actually were considering allowing that suffix to be exact to a manufacturer. So make it so that it was easy to tell, say, this is from XYZ manufacturer versus 123 manufacturer. But they determined that that wasn't really appropriate given how we approach the approval of medications. And so they had to go back and it's randomized. So even more fun because I think on one hand, I would think, well, why not just pick like, if you're this manufacturer, let's pick the first three letters or four letters of our names and make that our ongoing suffix. And they
Yeah.
actually said that's not in the spirit of how they would like for these products to be approved, and they randomize the letters. So they all have random letters that they check when they're coming up with the naming convention doesn't specify the manufacturer, with the thought that maybe over time that particular product could be produced by another manufacturer. Then would you change the name of it? All of those things. So just a bit of I think lore about how biosimilars and the pathway has come forward is that that's actually something they made a very distinct decision about following the approval of the pathway to develop biosimilars in the United States.
No, absolutely. And on our website, we have an actual biosimilar referral form, but you'll notice that we have the brand and the unbranded with the suffix for all of the biosimilars. So that we try to make it as easy as possible. But if you're ever working with another pharmacy and they refer to, Halima as BWWD, maybe just keep our referral form handy as a key to what that is translated to. But we'd love to hear feedback too. If anyone has any suggestions, regardless whether AcariaHealth is one of your preferred pharmacies or not, if without feedback, there's no way for us to continue to improve quality of care and set the highest standard of care. So we truly welcome that. If you're not comfortable speaking up, totally fine. Please put that in, even the Q&A. We'd love that feedback and truly value it.
So our Q&A is a little quiet as we come towards the end of the time. In order to spark some thoughts or get a chance for last minute questions, thought it would make sense for us to kind of round robin with, if you had one takeaway for the audience today, in addition to our appreciation for joining us, what would you like for them to share? And I think I'll start with Kathleen, since you kicked us off today.
Yep, I would definitely say stay informed. Keep your eyes and ears open for not only planned formulary changes, but changes to, like I alluded to earlier, how biosimilars become interchangeable. There's some legislation that is pending that may pass, may not, that says all biosimilars may be granted interchangeable designation without having to do additional studies. So things on the horizon to keep an eye out for. Just try to stay up to date as possible. The FDA has lots of really good resources. The FDA Purple Book is my best friend to see what is newly approved as biosimilar and interchangeable. So check those resources out. But that's what I would suggest. Robin, do you have something?
Yeah, it's collaboration, right? It's working with your specialty pharmacy. It's education, utilizing some of the tools that we have for you. We have some amazing pieces on our website. It's also understanding, at the end of the day, specialty pharmacy, what I've always said, the two things that really truly set us apart is going to be the level of our customer service and expertise, right? But also the rep. And when I say rep, that means, that could be an internal person that you talk to, that could be an external person, that could be one of our provider experience managers. Those are the two things that really set us apart. And who's going to go that extra mile to minimize the paperwork and that administrative burden for you, while providing the highest standard of care and continuity of care to your patient. And I want to leave you with that, because I truly believe that AcariaHealth sets a very high standard when it comes to that. And we want the collaboration with you as our peers to see what we can do to improve communication and help you navigate this landscape. So thank you all for joining the call. I really appreciate your time and letting me talk so much today.
And so I'll wrap
Alysha.
it up then here and just say that, like I said, our greatest appreciation for joining us today and allowing us to share with you our insights. And just, a reminder that, as Robin mentioned, as Kathleen mentioned, this is a highly complex situation. It's going to continue to grow, and it's a new frontier for us to explore ways to better partner with you as we manage together these patients and get them connected to care. As a pharmacy, we have the unique position of being a part of the access picture that actually gets the medication in the patient's hands, and we don't take that lightly or for granted. And so as you think about what your patients who are newly having the option for biosimilars, or maybe having a requirement to start using them, what pharmacy to partner with to maintain that care, we hope that you continue to consider us. And in the meantime, leverage our resources that we have available through the QR code. And also, there's contact information to outreach us so that our team members can stay connected with you. So with
Absolutely.
that,
And I do believe an email is going to be going out, right, with the recording as well as the links to our biosimilar resources. Is that correct, Kathleen?
Yes, it is. So definitely
Okay,
be on the lookout for
perfect.
that email so you can have all this wonderful information at your fingertips, and certainly reach out if there's anything that we can help with.
Awesome.
Thank you all.
thank
Thank
you.